placebo in patients with refractory metastatic gastric cancer. Tobias, please go.
Great, thank you. Dear Chairman, ladies and gentlemen, thank you first of all for inviting us to present this abstract here at the oral GI session. And I'm very delighted to present on behalf of my co-authors the TAC study. The TAC study is a phase 3 randomized double-blind study of trifluridine tipiracil, or known as TAS 102, versus placebo in patients with advanced gastric or gastroesophageal cancer. These are my disclosures. Gastric cancer is the 5th most common cancer worldwide and the 3rd most common cause of cancer-related death. Metastatic gastric cancer is a poor prognosis with a 5-year overall survival rate of 4%. There is a high unmet medical need in heavily pretreated patients with gastric or gastroesophageal cancer. Therefore, and in this context, trifluridine tipiracil, or also known as FTD-TPI, is a novel oral therapy comprising the thymidine analog trifluridine and tipiracil, which prevents trifluridine degradation. FTD-TPI is approved for metastatic colorectal cancer as part of the RECOURSE trial. The recent phase 2 study, Japanese study EPOCH 1201, evaluated FTD-TPI in patients with metastatic gastric cancer who failed standard of care chemotherapies, including fluoropyrimidines, platinum, taxanes, or irinotecan. Median overall survival was 8.7 months. The disease control rate was 65.5%. The TAC study was a multi-center, randomized, double-blind, placebo-controlled phase 1 study, which was performed at 110 sites globally in 17 countries. Patients with metastatic gastric or gastroesophageal cancer who have received 2 prior lines of treatment, at least 2 prior lines of treatments, were randomized in a 2-to-1 fashion to either FTD-TPI or plus best supportive care at 35 milligrams per meter square, twice daily oral dosing, day 1 to 5 and 8 to 12 of a 28-day cycle, or to placebo plus best supportive care. Patients were stratified according to region, treatment with ramucirumab or not, and ECOG performance status 0 and 1. The primary endpoint was overall survival. Key secondary endpoints were progression-free survival and safety. Other secondary endpoints were overall response rate, disease control rate, quality of life, and time to ECOG performance 2 deterioration and above. Patients were treated until disease progression, intolerability, or patient withdrawal. A total of 507 patients were enrolled and randomized to the study, 337 patients to the FTD-TPI group, and 170 patients to the placebo group. Baseline demographic and disease characteristics were generally very well balanced between the both treatment groups. The study population was representative of what we usually see in gastric cancer trials. 71% of patients had gastric cancer, 29% had gastroesophageal cancer. 44% of the patients had a prior gastrectomy, and more than 63% had 3 or more prior treatment lines. So this is really to highlight how heavily these patients were pretreated. Also, the number of metastatic sites was more than 55% in 3 or more sites of metastatic disease. 19% of patients had HER2 status. All patients, in terms of prior treatments, had a platinum-based regimens. All patients, but 1 patient in the FTD-TPI group had a fluoropyrimidine treatment, taxane, irinotecan, ramucirumab, anti-HER2-directed therapy, and immunotherapy followed. Importantly, 25% in both groups received follow-on treatment. There was no crossover. The primary endpoint overall survival was met. FTD-TPI demonstrated a clinically meaningful and statistically significant improvement in overall survival compared to placebo, as seen at the early separation of the overall survival curve, which was also maintained. This risk reduction, there was a 31% risk reduction in death, and which amounted to a median overall survival of 5.7 months in the FTD-TPI group and 3.6 months in the placebo group. This was highly statistically significant. At 12 months, 21% of the patients in the FTD-TPI group were alive and 13% in the placebo group. Subgroup analysis of overall survival according to baseline demographic and disease characteristics favored FTD-TPI over placebo in most subgroups analyzed. In a pre-specified multivariate Cox regression analysis, no baseline patient or disease factors analyzed were identified to be as being predictive. The multivariate analysis showed that several factors were prognostic. ECOG performance status 0 versus 1, age less than 65 versus older than 65, prior regimens 2 versus more than 3, metastatic size 1 or 2 versus more than 3, and HER2 status. However, after adjusting for these factors, the treatment effect of FTD-TPI was maintained with a hazard ratio of 0.69. FTD-TPI also demonstrated a statistically significant improvement in progression-free survival compared to placebo. The risk of disease progression was 43% lower in the FTD-TPI group compared to placebo. Median progression-free survival was 2 months in the FTD-TPI group and 1.8 months in the placebo group. It should be noted, however, that the estimates of median progression-free survival were affected by the timing of the first on-treatment scanning or tumor assessment, which took place at about 8 weeks or 1.9 months from treatment initiation. PFS was longer with FTD-TPI than with placebo in all pre-specified subgroups, including primary site, HER2 status, number of metastatic sites, number of prior regimens, and prior treatment with ramucirumab, irinotecan, or taxanes. Tumor response was evaluated in 86% of the patients in the FTD-TPI group and 85% in the placebo group. Overall response rate was 4% in the FTD-TPI group and 2% in the placebo group. Importantly, the disease control rate, which included response but also disease stabilization, was 44% in the FTD-TPI group and 14% in the placebo group. The 30% difference was statistically significant. Median time to ECOG performance deterioration of 2 or more was also longer in the FTD-TPI group. There was a 31% risk reduction of the performance status deterioration. Safety was assessed by the investigators among all patients who received at least 1 dose of treatment, 335 patients in the FTD-TPI group and 168 patients in the placebo group. AEs of any cause were reported in 97% of patients with FTD-TPI and 93% in the placebo group. Grade 3 or higher adverse events of any cause occurred in 80% of FTD-TPI treated patients and 58% in placebo patients. With FTD-TPI, the most frequently reported grade 3 or higher AEs of any cause were neutropenia, anemia, and leukopenia. Grade 3 or more febrile neutropenia was reported in 6% or 2% of the patients who were treated in the FTD-TPI group, but no patient in the placebo group. With placebo, the most frequently reported grade 3 or higher adverse events of any cause were abdominal pain, general performance or health deterioration, and anemia. In both treatment groups, 1 death was related to treatment. In the FTD-TPI, it was a cardiovascular event, and in the placebo group, toxic hepatitis. How were the adverse events managed? Dose modification, which consisted of dosing delay or dose reductions due to AEs of any cause, were reported in 58% of patients in the FTD-TPI group, 22% in the placebo group. 11% of patients in the FTD-TPI group and 1% of patients in the placebo group had at least 1 AE, which caused to or led to dose reduction. AEs of any cause led to discontinuation of treatment in 13% of patients with FTD-TPI and in 17% of patients with placebo. G-CSF was administered as a supportive treatment for neutropenia in 16% of patients in the FTD-TPI group and 2% in the placebo group. In the FTD-TPI group, the most frequently reported AEs of any cause leading to dose modification were neutropenia, anemia, and leukopenia. So let me summarize. FTD-TPI showed a clinically meaningful and statistically significant improvement in overall and progression-free survival compared to placebo in heavily pretreated patients with gastric and gastroesophageal cancer. was a 31% reduction in the risk of death and a 2.1 months improvement in median overall survival with FTD-TPI over placebo. Additionally, patients in the FTD-TPI group had a significant higher disease control rate, the lower risk of ECOG performance status 2 or more deterioration compared to placebo. FTD-TPI showed a predictable and manageable safety profile consistent with what we have seen from the colorectal or gastric cancer trials. In conclusion, the data presented here demonstrate that FTD-TPI represents an effective and new treatment option for patients who are heavily pretreated. I'm very excited to announce that this study has just been published an hour ago in Lancet Oncology. Importantly, I also want to thank our patients and families who participated in this trial, clinical study teams, the data safety monitoring, and board members who participated in the study, Tayo Oncology, who sponsored this study, and of course all the investigators who participated in this study. Thank you very much.
Thank you very much, Dr. Arkenau, for a very clear presentation of clinically relevant data. We have 2 or 3 minutes time for question and answers, so if you want to ask a question, please go to one of the microphones and identify yourself.